Well, good morning, good afternoon, good evening to everyone joining us from near and far. We'll give people another minute to join, and then we'll kick off this webinar as a part of the series on universal health coverage and why it matters for all of us. And this is the session on the road to the 2027 high-level meeting on UHC, Milestones for Success by 2030. Your question, and yes, the recording will be made available, if not today, within a couple of days. Well, let's get started. Welcome again. My name is Jeff Lazarus. I'm the professor of global health at the CUNY Graduate School of Public Health and Health Policy in New York City. And you're joining us for the webinar series, UHC and Why It Matters for All of Us. We'll be together the next hour discussing with three panelists before we have a closing. I'll go through the agenda in a moment. All aspects of UHC, and this event is organized and sponsored by the CUNY Urban Food Policy Institute. Dr. Nevin Cohen will close the session representing the Institute. The CUNY Center for Immigrant, Refugee and Global Health, and thank you to my colleague Kathleen Carvero for helping to organize and set up this series, and the Global Think Tank on Steatotic Liver Disease, where I sit as director. Next slide. So, as mentioned, I'm Jeff Lazarus, dialing in from the CUNY Graduate School of Public Health and Health Policy, and joined for our presentations and panel discussion on advancing UHC by 2030 by Dr. Pamela Cipriano, who's the co-chair of UHC 2030. If you're not familiar with that organization, she will be telling us all about it. You should definitely receive their newsletter, and it's a very helpful website of evidence and information about all aspects of universal health coverage. And she's the past president of the International Council of Nurses, and it's actually from ICN that I know Pamela. Marika Kremen is the policy and advocacy manager of the NCD Alliance, bringing together hundreds of organizations working on different NCDs. And again, a very powerful website and newsletter with important information. And Dr. Vanessa Garcia Larson is the Chief of Risk Factors at the Nutrition Unit at the Pan American Health Organization, one of the bodies belonging to the World Health Organization based in Washington, D.C. And as mentioned, we'll have closing remarks from Dr. Nevin Cohen, the director of the CUNY Urban Food Policy Institute and chair of the Health Policy and Management Department at CUNY SPH. Next. Here's our images. So next. And let me turn to our first speaker. As mentioned, Pamela Cipriano has a distinguished background leading the International Council on Nurses, but is also co-chair of UHC 2030. She's also served as 2 terms as president of the American Nurses Association, and she really has a remarkably distinguished background, and I can't think of anyone better placed. Pamela, no pressure to introduce us to the concepts of UHC, why UHC 2030, and what can we expect here in the upcoming months and years on the road to achieving universal health coverage. So over to you. Thank you.
Great. Thank you, Jeff. I'm going to share my screen. And clearly, we know how important it is that we address UHC as a global and local public health priority. Everybody can see my slides okay?
Yes.
All right, great. We've all been chasing the Sustainable Development Goals for success by 2030. And of course, to many of us, The most important goal is goal 3, which is good health and well-being. The last significant setting of goals for universal health coverage, which is under 3.8, was the political declaration of 2023 that was passed at the United Nations. So it's been important to measure the progress and close the gaps where we're falling short, because 2030 is right around the corner. And we know we need to continue to have much stronger advocacy for achieving UHC. So let me tell you a little bit about UHC 2030. We are a global multi-stakeholder platform that has been developed specifically to sustain progress toward UHC. It grew out of the International Health Partnerships, so it was formally became UHC 2030 in 2016. The vision is that the world would, where all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. The platform is hosted by the WHO as our primary secretariat, along with the World Bank and OECD, and consists of a number of agencies, including country members, civil society, the private sector, foundations, UN agencies, and other international organizations, really dedicated to building and establishing equitable, resilient health systems that leave no one behind and are really the foundation for health security. So what we know as well, the UHC 2030 group developed much of the zero draft and the 8 action agenda items that went into the high-level meeting and what was adopted in terms of how we were going to reach UHC by 2030. So in that political declaration, the action agenda also was then adopted by the G7 health ministers in 2023. So there's been a lot of work over the last 2.5 years. However, monitoring and being able to look at results has been really important. So in December, UHC 2030 published our Act for UHC report, because we wanted to know, are countries really making good on their commitments? It is a global survey that brings evidence together to assess whether countries have translated their key commitments into the political declaration actions that were requested. Tracks progress on implementation, as well as looking at how do we drive policy and action based on those results for better health care. So I'm going to go through the 8 action areas with you briefly and identify the progress that's been made, as well as some of the gaps and vulnerabilities. The report does take into account a specific country context, which are really important because we know there is significant variability, and those could be how high is the trust in government? What are the socioeconomic conditions? Are there social protections? Is there civic participation? And what are the vulnerabilities to other issues like climate change? So there's 3 sets of indicators that demonstrate whether or not countries are achieving their SDG targets. And there is some good news and bad news in all of the measures. Not terrible news, but again, recognizing that we still have a ways to go. There are 4 key messages in the outcomes in this report. Foundations are strong, but impact has been uneven. There continue to be significant disparities and inequalities. We know that UHC builds resilience against health emergencies, but better data are essential. So the immediate takeaways, which also coincide with the WHO and World Bank Global Monitoring Report that was also released in December. First of all, start with the fact that we are pleased that more people worldwide do have essential health services. Fewer people are experiencing financial hardship due to health costs, but progress has slowed significantly over the last 5 to 10 years. So the numbers that we're looking at now show that 4.6 billion people are still not fully covered by essential services. Now, the biggest challenge in that, no surprise to all of you, is non-communicable diseases. The most progress, again, probably not a surprise, has been in infectious diseases, but much slower progress in areas like reproductive and maternal, child, and newborn health. We also believe 2.1 billion people are continuing to experience financial hardship, and that's actually 26% of the global population. And 1.6 billion are also either further pushed into poverty or are newly pushed into poverty. The largest expenditure, as you can imagine, is medicines. In 75% of the countries, that makes up 55% of out-of-pocket spending, and for those in poverty, 60%. Now, when we say there's less financial hardship, it's because overall there's been poverty reduction, but not necessarily targeted for health. So let's look at the 8 action areas, and I'll give you just a brief overview. So the number one is championing political leadership. The good news is 90% of countries have placed UHC at the center of their health policy. Leaving no one behind, a phrase you're very familiar with at the UN, means that health systems have to reach all, including the most vulnerable and marginalized. And again, progress where many countries are in fact including people regardless of immigration status. However, there still continue to be inequities. Adopting enabling laws and legislation. 78% of member countries have a constitutional right to health, but we really don't know how it's being implemented or interpreted. The healthcare workforce, we're very concerned about because we know there's a projected shortfall of over 11 million individuals by 2030. So we're concerned that there are issues of migration. 15% of workers around the world are actually in a country other than their birth origin. And so there continues to be significant maldistribution. Investing more and better really puts the spotlight on huge disparities in per capita spending. In high-income countries, $2,678 are spent versus in low-income countries, only $8.7 per person. So there's been a huge reliance, as you know, on external aid, and that landscape has changed dramatically, particularly since last year, with significant uncertainty. We also have a commitment to move together toward UHC, but progress again has been limited. And this is measured in an index about civic space, and only 20% of countries qualify as being open, and 26% are considered repressed. So this is an area where there needs to be more improvement. Guaranteeing gender equality is a significant area, and we think about the reproductive health as being one of the areas that's very far behind in terms of contraception and family planning. And what's going to help there too is we need gender disaggregated data and workforce reporting. And then connecting UHC and health security is probably under focus because what we know is that we need to be able to prevent, detect, and respond to public health emergencies while we are also able to continue routine service delivery. And so this is a big part of the global agenda. So what does all this mean? So as we're getting ready to think about getting to the next high-level meeting, which actually will be the last, we're not on track for UHC by 2030. The window is closing, and we need accelerated progress. Inequalities continue to be a major barrier. Now, there have been a number of solutions that have been proposed. Having free essential care for the most vulnerable, increasing public investment for prepaid coverage, decreasing high spending on medications and other out-of-pocket services, expanding access to NCD services and strengthening through primary health care for equity and efficiency, and adopting multi-sectoral approaches. What you see in the calendar here is the work that will occur between now and next September in order to be able to have adoption of another high-level agreement. So what's going to be in that zero draft? UHC 2030 has a specific task force that is crafting that language right now. And there's 2 primary areas of content. One is global financial architecture initiatives, which has been a focus of a number of groups. But really mobilizing domestic funding, increasing domestic funding has been a significant push, particularly in the last year. Better, efficient spending and getting rid of duplication and reducing the country debt, which is really crippling many of our nations. And then also all of the principles that we know are important for stronger primary health care, including NCD burden, reducing the costs, improving the quality, improving equity, making sure we have the right workforce, and a significant agenda under digital transformation. So what does all this mean again for the future? Essentially, all of us who are very concerned about universal health coverage for every country know it is not a destination. It's not going to be there on the dot of 2030. It is a journey that also needs to be sustained. So the post-SDG agenda has to be really embedded in how we look at equitable healthcare delivery, sustainable financing, and resilient systems. We want to really deliver on health for all and make sure that this is a principle of all global development. Thank you.
Thank you very much, Pamela. You set out very elegantly what universal health coverage is, where it's being measured and that it's, an integral part of our sustainable development goals that all countries have committed to, but also that, there are transparency and engagement, particularly with civil society challenges in many of those countries. So you set out a lot of different barriers, including not least the funding barrier. It's always about, do we have more funding? But there's also things, countries can do. We know from WHO that indicators aren't harmonized within those indicators, different ages, different definitions are used, and it's often very hard to get a read on how well we're doing towards achieving UHC. But at the same time, I think you're probably right that in 2030, most of the world will not have achieved at least the basic definition of universal health coverage, which makes the next 1.5 years, so crucial. And in that, timeline you set out, there are moments, we can come back to this in the question and answer for those who have a lot of experience in this space, like Marika as well, where civil society groups, where NGOs can engage as non-state actors or otherwise as a part of the consultation process to contribute to that political declaration. Because once we have that political declaration, it's a long time, before we have a chance, to go to the next one. So we're going to take some questions and answers at the end, but I will encourage everyone to use the chat for your comments, for your questions, so that the panelists and I can be looking at those. And now let me turn to our next speaker. Marika Kramen is the Advocacy and Policy Manager at the NCD Alliance. You're based in New York City and responsible for covering financing policy and UN advocacy. You'll provide reflections from the recent high-level meeting on NCDs that we both attended, including key lessons learned for achieving UHC by 2030 and inclusive of NCDs and importantly, mental health as well. So over to you. Thanks for joining.
Thank you so much, Jeff. And hello, everyone. It's wonderful to see you. I see some familiar names amongst the participants for the call today, so I know I'm among friends. So by way of introduction, NCD Alliance is a global alliance of over 500 member organizations, including over 70 national and regional alliances. We focus on system-wide solutions for NCDs, the big five being cardiovascular disease, chronic respiratory diseases, cancer and diabetes, and mental health and neurological conditions. And we are unified by the cross-cutting nature of NCDs' common risk factors of unhealthy diets, tobacco use, alcohol use, physical inactivity, and air pollution. What we try and do is seek to enhance global policy across NCD prevention, care, and financing by utilizing the expertise of our network, as well as bringing the voices of people with lived experience into decision-making. So for our NCD Alliance, we really truly believe, and as Pamela alluded to this in her presentation, that you cannot have UHC without NCDs. And I'm going to kind of walk through why that's important related to the three dimensions of UHC. So it's who is covered, what is covered, and how much it costs. So, in terms of who is covered and what is covered, we see a real sort of lag in NCD coverage among national health systems, despite NCDs being the highest disease burden globally. So they are the leading cause of death and disability. This is particularly and acutely felt in lower and middle income countries, where that mortality rate is approximately 85% of deaths being related to NCDs. And this is definitely, we see this coming through because the morbidity and mortality is directly related to the care that people are able to access to either prevent or control their conditions. For example, provider visits and medication for NCDs are roughly double that of infectious diseases in many countries. And that's because those countries have made different decisions in terms of what is prioritized under the health coverage that they provide at a public level. We also believe that care needs to be person-centered. We hear time and time again how important it is for people to go to one clinic and see one doctor and get the treatment that they need. And UHC is a really key part of bringing all of that together. UHC is also incredibly important to contributing to health system strengthening efforts that help not only NCDs, but other disease areas as well, healthcare workforce and training being a prime example of that. Next slide. So as Pamela mentioned, the process for UHC is already underway, and what I'm highlighting here is sort of the ramp up period that we as NCD Alliance have sort of developed and clocked based on our experience with the high-level meeting on NCDs last year. So this timeline shows all of the relevant processes and opportunities for advocacy that are relevant to the HLM. There are the usual opportunities like the WHO Executive Board and World Health Assembly meetings. There are ongoing partnership collaborations, as Pamela mentioned, through the work of UHC 2030. And of course, we also have identified key processes in New York on the HLMs for HIV/AIDS and pandemic prevention, preparedness, and response, because we see those as an opportunity to continue our messaging around integrated care and people-centered approaches. Next slide. And so if you thought this year looked a little busy, next year is going to be even crazier. Many of these processes Pamela walked through, but I just wanted to highlight again here that this process will sort of start in Geneva and then transition to a member state-led process here in New York. And what NCD Alliance will be doing in particular to engage in this is in both of those places. So I'm in New York, but the rest of my team is based in Geneva and has a lot of really good relationships with the permanent missions and WHO there. So while I will be here leading our UN engagement and talking to member states about what our aspirations are for this political declaration, and advocating for the strongest outcome possible, my colleagues in Geneva will be communicating with the missions there to pick up on additional intelligence from them on national positions, as well as from WHO, to try and put together a picture of what is actually happening in these negotiation rooms, because they're closed and open only to member states and official UN observers. So we as civil society are not allowed to be in that room. Next slide, please. So some of the key activities that we have found to be particularly useful throughout our engagement in HLMs is the co-development of advocacy priorities with our network. So we are going out to our membership, engaging in consultations about what issues are really important to them. And because, as I mentioned, we have over 500 members and great regional representation, I think we're very privileged in that we can sort of pull together a sort of very informed, holistic response on global needs. This also helps increase civil society buy-in and excitement about the process, which is so important to continue to engage in these month-long advocacy efforts. We don't do any of this alone. We work in coalition. So there are groups like the CSEM, the Civil Society Engagement Mechanism for UHC 2030. We also have our place in some of the formal UHC 2030 bodies and other relevant fora. And then, of course, as I mentioned, I'm here in New York doing those bilateral meetings and face-to-face engagements. But then probably the sort of pinnacle of all of this is the multi-stakeholder hearing, which is the perhaps most important, most direct point of entry for civil society to contribute to the process, and be at the UN itself to tell member states directly what it is that they're looking for from this outcome. Next slide, please. How can you get involved in any of this? Well, the most sort of obvious, simple answer is to join our network. And you can check us out online to learn more about that. We have a number of different tiers based on how you want to engage with us. But we do have a public-facing campaign that everyone is able to join, the Global Week for Action. So the website for that is Act on NCDs. Here we put out free materials for people to use for engagement with their governments in capital in New York if they're interested. And it's really to sort of help lower the barrier of entry for organizations that aren't very familiar with these multilateral processes, because I'm here in New York and sometimes I even get a little confused about who I'm supposed to talk to about what at what time. So we're trying to simplify that for all of you. So that is going to conclude my presentation today. Apologies again for the technical snafu, but I'm looking forward to fielding any questions that you may have in the chat or in Q&A later. Back to you, Jeff.
Thank you so much, Marika, for that frank look into not only how the NCD Alliance works, but also a little bit into your life in New York. I particularly appreciated that it can be a little confusing who to talk to, but I'm worried because if you're confused, I don't know who's going to know who to speak to.
No, I think I've got it at this point, but I appreciate that it's not the most transparent.
No, it is complicated also because, you know, the permanent missions are different from the ministries of health, are different from ministries of foreign affairs. So there's a lot of players going on that all need to align. I mean, universal health coverage is really not just a health issue by any means. I can tell you, you have all the support of CUNY that you need at all levels, and there's no shortage of human resources. We have over 250,000 students in the CUNY system and thousands of professors, instructors, and staff who all strongly believe in universal health coverage. So let me turn to our third and final panelist, Dr. Vanessa Garcia Larson. Serves, as mentioned, as the chief of the Risk Factors and Nutrition Unit at PAHO, so part of the World Health Organization. And your unit leads efforts to support member states with the implementation of WHO measures to reduce harmful risk factors for and the burden of non-communicable diseases. So for you, UHC is really your bread and butter and exactly what you need as an organizing framework. You're going to talk to us about planned approaches for promoting and supporting UHC from your unique PAHO's perspective, which complements the perspective of UHC 2030, which is outside the UN, but also with a secretariat at WHO and the NCD Alliance, which brings together those 500 different NGOs. So over to you, Vanessa. Thanks for joining us.
Thank you, Jeff. Thank you so much for inviting PAHO to be part of this very important dialogue. And I'm delighted and honored to share the panel with these two distinguished colleagues. So to follow on from what Pamela outlined before, in 2023, during the second high-level meeting on universal healthcare, member states unanimously recognized that universal healthcare is fundamental to achieving all of the Sustainable Development Goals, not only those related to health and well-being, but also, importantly, those related to poverty eradication, access to education, gender equality, climate change, and building peaceful and inclusive societies. The 2025 revised Global Universal Healthcare Monitoring Framework uses a new set of indicators, UHC service coverage indices and index, and proportion of the population facing financial hardship in health. And this figure just summarizes where we are now with this global service coverage index. The projected global service coverage for 2030 is 74 out of 100, and it is also anticipated that 24% of the population will continue to face financial hardship. Now, global progress in service coverage index has been driven primarily by infectious disease control, which is accountable for 52% of the increase in service coverage since 2000. Reproductive, maternal, newborn, and child health services have stagnated in recent years at 72 index points. And I think the biggest gap, as Marika outlined before my presentation, is the issue of care for NCDs, which has lagged, reaching 61 index points in 2023. So within this context, the Pan American Health Organization produced a report documenting the progress of universal healthcare in the Americas. And it is clear that achieving universal access to health and universal health coverage remains an elusive goal for many countries in the Americas. Despite significant advances, the region continues to grapple with persistent challenges, and these include health systems fragmentation, weakened stewardship and governance, and inequitable access to services, particularly among populations in vulnerable situations. A third of the population in the Americas continues to face barriers in accessing care, with significant disparities in the availability of human resources for health and also access to essential medicines and technologies. And these challenges have resulted in equitable access to health services and emerging health threats compounded by social determinants of health. So in response, there has been growing momentum across the region towards achieving universal healthcare through primary healthcare actions, and they are driven by international commitments and regional frameworks that prioritize health as a central pillar of sustainable development. And this diagram here illustrates the WHO operational framework for primary health care, which provides a comprehensive blueprint for countries to advance towards universal healthcare to a primary healthcare centered approach. And this framework outlines a set of interconnected levers designed to transform global commitments into tangible actions for achieving universal health. And you can see here in this diagram that we have at its core a framework that it's organized around 17 levers, 4 strategic and 10 operational. And the integration of the set of those two sets of levers is critical to have success with the implementation of effective primary healthcare actions. So in 2023, the Pan American Health Organization introduced the Better Care for NCDs initiative, which aims to expand equitable access to integrated and comprehensive NCD services within primary healthcare services in the Americas. The Better Care for NCDs non-communicable disease initiative promotes a shift that goes beyond treatment. Importantly, it supports prevention, risk factor control, and active health promotion within communities. So it also integrates what Marika was mentioning before about person-centered services. It also strengthens local teams, improves care coordination, and ensures that essential services reach those who need it the most without fragmentation or delays. Now, the initiative's framework of action is focused around 4 main pillars: risk factors control, and that includes tobacco control, excessive alcohol consumption, unhealthy diets, physical activity, addressing physical inactivity as well. And importantly, the WHO best buys are embedded into primary healthcare. Now, the CKM continued includes diabetes, hypertension, lipids, kidney disease, and cascades for diagnosis, treatment control, essential medicines, and diagnosis. The initiative also recognizes the critical importance of chronic respiratory diseases, now recognized as the 3rd world cause of death, primarily asthma and COPD, and cancers. And through cancers, the elimination of cervical cancer, and the screening for early detection of breast cancer. So by 2030, expected that at least, hopefully, more than 20 countries in the region of the Americas are going to have 80% of primary healthcare facilities delivering and monitoring integrated NCD care. But what's the situation at the moment? This is an illustration of unmet healthcare needs in the PAHO region, and that's why we believe so strongly that addressing primary healthcare services with an integrated approach that recognizes the multidimensional nature of NCDs, death prevention, management, and premature mortality control is so important. So you can see here the huge variations we have across the region, with some countries having 3% of unmet healthcare needs, and others concentrated in South America having the greatest proportion of unmet health care needs. And another important finding of this report is that organizational barriers are the most common cause of unmet healthcare needs. And you can see it here, over 20% of the reasons are due to organizational barriers. So it becomes more important than financial accessibility or geographical accessibility, the latter being a very important issue in the Americas, given the huge variations between rural and urban environments for access. So what are the recommendations we are left with at the moment? Clearly, strengthening primary health care and prioritizing health equity are essential for the region's pursuit of a sustainable and inclusive path towards universal healthcare, ensuring that every individual is able to attain the highest standards of health and well-being. And PAHO is proactively acting towards achieving this goal through the Better Care for NCD strategy. And for this strategy to work, we are already implementing a number of actions that require intersectoral cooperation, civil society, academia, etc., to participate. So all those who are here with us today are invited to be part of this important dialogue. And a critical aspect of advancing universal care through primary health care is, of course, the adoption of a territorial approach which recognizes the diverse health needs and context that exists within countries. We all know that the Americas in particular, we have 37 member states, and the differences between sociocultural, geographical, and sociodemographic characteristics vary hugely across the region. So that's a very important aspect to consider when we try to progress the dialogue to advance universal healthcare. So thank you all so much for giving me the opportunity to highlight these facts. Thank you.
Well, thank you. Thank you so much, Vanessa. It's amazing work that PAHO is doing, and quite a detailed presentation. I'm going to call back our other two panelists. There's a number of questions in the chat, but I wanted to just kick us off with, a lot of work is going to go into the next year and a half around achieving the best political declaration possible. But we know what universal health coverage is. We have previous declarations. It's in the SDGs. We're working towards it. So something that comes up a lot is, do we need another political declaration? Is the juice worth the squeeze, or should we work? If we already heard from each of you that we're not achieving, whether it's NCD specifically or primary healthcare or so many other aspects of universal health coverage, do we want to put the resources of the NCD Alliance, UHC 2030, and PAHO kind of even on this webinar into that political declaration in the process, or is it so important that we should? Who would care to respond to that easy question?
Well, Jeff, let me just take a first pass at it. And that is that as we've been preparing and working now with our newly formed multi-stakeholder task force, what we have said is this cannot just be a reiteration of previous high-level meetings and political declarations. We don't want to say the same thing for the third time. This has to be definitive action orientation. And again, with measurement, to be able to say that country commitments have actually led to implementation of those commitments, of the inclusion in laws and regulation, the ability to measure outcomes, not just promises. So whatever happens with this 2027 declaration, because we think it should be the last one, it should be one that is binding, in terms of saying that countries have made a long, sustainable commitment to be able to put in place these systems. And as you've heard both from Marika and Vanessa, the fundamental groundwork is bringing primary health care to the forefront for person-centered care, for the inclusion of all of these conditions, including mental health, but also really a focus then on boosting health security, which is something that covers the peacemaking, it covers the collaboration. So I think it is a watershed moment to say if we address these and really with real teeth, then it could have significant ramifications across many areas.
Well, thank you. I mean, we've gone from the Alma Ata Declaration, which defined WHO's work up to 2000 and the MDGs to UHC, and the messages and the languages change a little bit, but not a lot. Marika, Vanessa, I mean, we don't have a choice. So that's also one reason to do it.
I think opportunities like this are extremely important. I think we have plenty of reasons to strengthen cooperation, and actually the NCA Alliance is a close friend of PAHO, and I think if we can enact or effect actions here to move forward integrating primary health care with the perspective of the NCD Alliance that brings civil society, the reduction of risk factors that are harmful for NCDs is extremely important, because ultimately the work we do has to reach out to the people affected by or at risk of NCDs. And it's a plethora of NCDs, actually. We are addressing the 3-4 most common, but we know there are another good cluster of NCDs that are going to claim significant numbers of premature deaths in the coming years. So absolutely, I think we are open for this sort of cooperation, and we need the help. I mean, intersectoral cooperation is more important than ever.
Yeah, and I think I'm going to maybe take still a yes answer, but approach it from a different perspective. From a civil society perspective, these high-level processes, yes, are very important to us. They are great advocacy and accountability tools. And I think that with big gaps between high-level meetings or them ceasing completely, you lose the political will of governments to act on these issues. But information is changing all the time. And so these high-level processes can sort of account for new best practices, reaffirm commitments, and civil society can use that to hold their governments to higher standards. Ideally, everything's progressive. But I also think that this meeting is happening at a really interesting time. So for those who are following global health at the very sort of high esoteric level, there are a lot of discussions around global health architecture right now and how it can be reformed to be fit for purpose in our modern world. And a big component of that is going to be centering health systems and technical packages, assistance from multilaterals, and financing in a new way. And UHC is going to be a big part of that. And so I think that, if I'm being very idealistic here, this high-level meeting in 2027 is a great opportunity to make that political commitment in another space, in another fora, and in another way that just continues to reaffirm member states' action for health.
All three responses were really convincing. Thank you. And yeah, these meetings help raise awareness about it. I mean, here now people are talking about UHC again instead of something that was discussed years ago during the last high-level meeting. And we can not only hold governments to task, but also, push the envelope a little bit, like you said, Pamela. Hopefully this is the last time, and then we have this in place and we're monitoring and improving health and not looking just towards the next political declaration or high-level meeting process. So there was a question, and I see you've answered it, Pamela, but let me raise it, and then you can reiterate for those not necessarily reading the chat, and also we're recording this. But there were questions around specific strategies undertaken by countries to finance UHC that have shown some measure of success.
Yeah, so one of the things that a number of countries have put into place, which may have seemed controversial at the start, but I think have proven successful in many ways, is deterrence, such as taxation on health-harming substances. So very commonly, we've seen taxes being put on alcohol, tobacco, and sugary drinks, and any other processed foods in general, and that has actually been accepted in many places. Obviously, it's not as popular within those industries, but again, I think it's one way that people can then make choices. The other area that's had a lot of discussion, a little less progress though, is saying how do we keep the external information that's coming from the companies responsible for these health-harming substances, as well as things like the very high-cost medications, from being overly influential to the public. So efforts to curb some of the marketing activities and, again, have some government controls over the information flow. Again, not highly popular in some places, but recognizing that if that is having an undue effect, then governments are taking action to say, we want to be the ones that educate our public about, healthy eating and healthy ways to improve diet and lifestyle that are able to work on some of those upstream issues with our NCDs.
You. I mean, I think you're alluding to the commercial determinants of health and the fact that, industries are creating many of these problems. Other industries are trying to get us out of these problems, and we really want to be able to take control of our lives, but it's not so easy. 24% of the world's population, you mentioned, Vanessa, will face financial hardship. We know there's huge issues around out-of-pocket expenses, including catastrophic, health expenditures. So people face real challenges, but they also face challenges, as you know, in Marika, just finding healthy food. Come visit our campus up in Harlem and try and look for a salad, and it's far and few between where you can find healthy food, and when you do, it's quite expensive, and even more expensive than those fast foods. Not to mention everything else that's being marketed at us around, tobacco, alcohol, and so on. So taxation has been shown to be successful, from minimum unit pricing on alcohol to taxes, on tobacco, to front of package labeling, where there's a lot of resistance. I'd be remiss directing the global think tank on steatotic liver disease if I didn't ask for a disease that has been around a long time, has had very little recognition, and now has a new name, including MASLD and MET-ALD, so metabolic dysfunction associated steatotic liver disease. How, not being a single issue person, but how does the field, how do we get that into universal health coverage? Can that get included in a political declaration, even as a footnote mention, or is the ship already sailing along the known harms and diseases? Any comment on how steatotic liver disease, which is really the hepatic manifestation of metabolic syndrome, can be included in this basket of goods? Vanessa?
Thank you, Jeff. So one of the critical features with MASLD is that it's silent for some time, and there is a window of opportunity that is limited there, whereby a patient with MASLD can actually restore the liver to normal conditions, but then there is a point of no return. The condition is irreversible. And I think what we are doing at the moment is addressing elimination strategies and screening to prevent major diseases. Now, with MASLD becoming the first reason for liver transplant, I think we're going to face a huge public health problem in just a few years. And the risk factors for MASLD are metabolic. So if we're addressing physical activity, healthy diets, we are going to also address MASLD, and perhaps early screening at the primary healthcare sector might be an opportunity for that. If a person has a profile whereby it is suspected that they have MASLD, there is a subsection of the population who could be screened and identified whether they have a clinical condition. Screening is cheaper than having to deal with a clinical condition. But I think we need to recognize that the risk factors for MASLD are pretty much common with them, very similar to the other major NCDs we are having to tackle at the moment.
Thank you. Pamela?
Yeah, I would add to the discussion. I would go back to what Marika said, which is maybe the approach is really looking at what can we do to continue to educate around the conditions that are part of NCD issues and the upstream issues. It was very interesting. Yesterday, I was listening in my car to BBC, and they actually had a very informative discussion around steatotic liver disease. And it was just like out of the clear blue. But again, talking about the risk and the number of individuals that eventually will be affected. I mean, it really shed a spotlight to a lay audience about what this means. So as I think about the work that the NCD Alliance is doing, and I think about the influence point being our member states and the great work that you and your colleagues have been doing, Jeff, this is really a time, I think, to bring that information to the forefront, get it out of the medical circles so that it actually resonates with the public, recognizing that it's attached to all these other diseases. And there's a spectrum of harm that's occurring, because I know there's not an appetite to go back and insert any additional new disease process or categorization within the documents. I think, as you said, maybe that horse has left the barn, because it is more important to focus on upstream prevention and management now. So how do we insert this new information, well, what is new to people, to say this is a really serious concern? And guess what? It hits at least 3 or 4 other really significant NCDs, because it is part of the progression of illness, and we want to keep people healthy. So I think continuing to focus on that public campaign and information can be really valuable right now.
Thank you. And a last brief comment from Marika. I'm going to wrap up and then pass over to Dr. Cohen.
Sure. I just want to, emphasize what both Pamela and Vanessa have said. I think, as we saw with the NCD process last year, that taking a sort of comorbidity angle has been really successful for other non-communicable diseases that are outside that sort of 5x5 matrix. So, for example, oral health has done, I think, a very good job at emphasizing their links to NCDs to, find their place in those documents. And I think the point of taking this outside the health sector as well is really important, because, as you mentioned, I cover financing, and there's always a question of how is this going to pay for it? So that economic case for why we need to address it as in both a prevention and care form, to justify the spending that will need to happen within health systems will be, I think, a sort of key part of operationalizing it.
Well, thank you. I mean, we're at also a unique opportunity with the World Health Assembly, with the first proposed resolution on steatotic liver disease, which would be a landmark change, because it would really, empower WHO to address this. From the liver field, we believe we need to name it, to act better on it. But of course, like you said, Vanessa, and we know we're addressing many of those risk factors, but people need to know there's one more problem. If they don't, they're not able to change their lifestyle, and they also need to know why it can be difficult to change those lifestyles. Let me pass over to you briefly, Nevin, to wrap up from the CUNY perspective. And before I pass over, thank you so much, Vanessa, Pamela, and Marika. It's been great working with you preparing this. We have a long road ahead, all those timelines. You said it's a busy year this year, Marika, and it'll be busier next year. But, a huge thanks to all 3 of you and your organizations for your work, the work you're doing really to, raise awareness around NCDs, but also to push the UHC agenda. Nevin?
Thank you, Jeff, and thanks to all the panelists. This was a really rich discussion, and I'm delighted that we were able to participate. I am the director of the CUNY Urban Food Policy Institute, and our mission is to help cities create healthy, just, and resilient urban food systems, and as a result, reduce NCDs. I want to point out a few things. The global debate that we've been talking about today lands in a really literal sense in our own city. We're just a few miles from the UN. What I glean from the discussion today is that we have our work cut out for us. The global state of UHC is really sobering, with billions of people lacking full coverage, 2 billion facing financial hardship from out-of-pocket health costs. And as we know, NCDs are the world's leading cause of death. And the same pattern of stalled progress shows up at every scale. And I want to emphasize the role of scale in this discussion, from the global to the neighborhood. In New York City, life expectancy varies by more than a decade across neighborhoods that are a single subway line apart. So a few lessons from the discussion. One is UHC is a political project, not a technical project. As Dr. Cipriano showed us, the accountability machinery is maturing globally, but the commitment to cover 1 billion people by 2025 hasn't been on track. And so we need to think about new political strategies to advance UHC. And I would just argue that the urban and the urban region scale is an important place to focus. In New York City, our city has been proving ground for many important policy ideas, from trans fat bans to calorie labeling to sodium warnings. And Dr. Garcia Larson reminds us that the Americas region as a whole leads on food policy innovation, from Chile's warning labels to the Mexican sugary beverage tax to restrictions on marketing to children. A second lesson I took from the discussion is that the commercial determinants of health are not a side conversation. They're really front and center. And in all of our discussions, we need to continue to focus on what cities and city regions and states can do to regulate commercial determinants like marketing, labor processes. Platform labor, for example, is one issue that we've been focusing on, and changes to food retail that directly affect NCDs. A third lesson, and I want to be brief because I know we want to wrap up, is that I think UHC is really built in cities and regions, not only at the UN. And we have examples here from New York City. New York Health and Hospitals is the largest municipal health system in the US and serves everyone regardless of their ability to pay or their immigration status. And much of that workforce is actually trained at CUNY. This is actually UHC in practice at the city scale, and I think it would be worth thinking through how networks of cities can learn from each other about advancing UHC. We've been involved with international city networks like the Milan Urban Food Policy Pact that have been advancing healthy and resilient food policies across the global north and global south. And these kinds of networks, from C40 to ICLEI, really are opportunities to advance UHC priorities when UN negotiations are slow or potentially stalled. And in a moment when federal support for health, especially in the US, is uncertain, and global declarations are hindered by economic interests, I think subnational leadership matters even more, not less. So thank you. This is food for thought, and I look forward to further discussions on these topics.
Thank you, Nevin. Thank you again to all the panelists, and thank you everyone for joining us. As written in the chat, we're going to share this recording. We're going to invite you to the next webinars, and there's a huge process in front of us. So check out the NCD Alliance website, the PAHO website, and the UHC 2030 websites. Have a great rest of your day, wherever you are.
Thank you.
Thank you.